Most conversations about prostate cancer treatment focus on making the case for a particular approach. Surgery advocates describe its benefits. Radiation oncologists describe theirs. Patients are left trying to navigate between two professionals, each of whom has genuine expertise in their own specialty. What happens far less often is a radiation oncologist sitting down and telling you clearly when radiation is probably not your best option. That conversation is harder to have, and in my experience, it is the one patients most need to hear. I am Dr. John, and today I want to give you exactly that conversation. Not to steer you away from radiation, which remains an excellent treatment for many men with prostate cancer, but to give you the honest, complete framework for understanding when the conditions that make radiation work well may not be present in your specific situation. Let me set the scene with a patient scenario that will carry us through this entire discussion. John is 65 years old. He has just been diagnosed with unfavorable intermediate risk prostate cancer. He has met with both a urologist and a radiation oncologist, and both have told him that surgery and radiation are both reasonable options for his disease. John has heard good things about radiation and is leaning toward it. His question is simple. Is there any reason he should not choose it? There are several possible reasons. None of them is an absolute rule that automatically eliminates radiation as an option. Think of them instead as a checklist. Each factor that applies makes radiation a less attractive choice compared to the alternatives. Taken individually, most can be managed. Combined, they begin to shift the balance. Reason 1. Severe pre-existing urinary obstruction symptoms. This is the most common reason in clinical practice that radiation becomes problematic. When men come to clinic before treatment decisions are made, they complete a questionnaire called the IPSS, the International Prostate Symptom Score. It runs from 0 to 35. A score of 5 indicates minimal symptoms. Scores of 20, 25, or 30 indicate significant obstruction. Here is why this matters for radiation. The prostate already acts as a partial obstruction of the urethra in men with BPH. When radiation therapy is delivered to the prostate, it causes temporary inflammation of the gland as part of its therapeutic mechanism. That inflammation temporarily swells the prostate further. In a man who already has significant obstruction, this additional swelling can convert a difficult urinary situation into complete urinary retention, where the patient cannot urinate at all and requires emergency catheterization. If the urine backs up sufficiently, kidney damage can result. An enlarged prostate on imaging alone is not disqualifying. What matters is the combination of high symptom burden, significant post-void residual volume confirmed by ultrasound, and inadequate response to medications like tamsulosin. In these cases, a deobstructive surgical procedure such as HoLEP or TURP performed first, followed by radiation once urinary symptoms have stabilized, is often a more sensible sequence than proceeding directly to radiation. John's IPSS score is 5. This is not a concern for him. Reason 2. The psychological need to have the cancer physically removed. This may seem less medical than the other reasons, but it is both common and entirely legitimate. Some men have a deeply felt conviction that cancer must be excised from the body, not treated in place. They find it psychologically difficult to proceed with a treatment that leaves the prostate, and theoretically, the cancer physically present while being treated by radiation from outside. I do not personally view treatment this way, but I have enormous respect for this perspective when patients hold it. Psychology is a genuine and powerful component of treatment experience and recovery. A patient who is fundamentally uncomfortable with their choice, no matter how medically sound it may be, is not in an optimal position to complete and benefit from that treatment. If this describes you, your instinct toward surgery deserves to be honored rather than talked out of. Reason 3. Inability to maintain a full bladder. Radiation therapy to the prostate requires consistent positioning of the prostate and the surrounding structures during each treatment session. A full bladder pushes the bladder wall upward and away from the prostate, meaning only a very small portion of the bladder receives significant radiation dose. An empty bladder, by contrast, drapes downward over the prostate and receives substantially more radiation than intended. Some men have conditions, severe overactive bladder, advanced BPH, or other medical causes that make maintaining a consistently full bladder during treatment simply impossible. When this is the case, the geometry of each treatment session becomes unpredictable, making it considerably more difficult to protect surrounding structures from unnecessary radiation. Reason 4. Inability to maintain an empty rectum. The counterpart to the full bladder requirement is an empty rectum. The rectum sits directly behind the prostate. When the rectum is empty, it stays away from the prostate and receives minimal radiation dose. When the rectum is full, it physically pushes against the prostate, displacing it from the position that was planned for treatment. The machine delivers radiation to where the prostate is expected to be. If the prostate has been pushed away from that position by a full rectum, the treatment misses part of its target. For stereotactic body radiation therapy, which delivers radiation in just 5 highly precise sessions, an enema before each session is strongly recommended and frequently required. Men who are chronically constipated and who are unwilling or unable to manage bowel preparation for each session face genuine logistical challenges with this approach. This is rarely an absolute barrier, but it is worth understanding clearly before committing to this treatment schedule. Reason 5. The belief that surgery now preserves radiation as a future option, while radiation does not preserve surgery. This reasoning is heard frequently and contains a kernel of truth that is, however, substantially overstated. The truth within it: radiation therapy causes scarring in the treated area. If surgery were subsequently required in an area that has been previously irradiated, it would be technically more complex, and most surgeons prefer not to operate in a previously radiated field. Surgery after radiation is not impossible, but it is more challenging. The overstatement. This argument implies that needing surgery after radiation is a common scenario. The data does not support that implication. With modern radiation techniques, local recurrence within the prostate, meaning cancer returning within the prostate itself after radiation, occurs in approximately 5% of patients. Compare this to the rate of local recurrence in the prostate bed, the area where the prostate previously sat, after surgery, which is considerably higher, sometimes 30 to 50% depending on risk group, and which typically requires post-operative radiation. Furthermore, when prostate cancer does recur after radiation, it almost universally recurs at distant sites, in lymph nodes or bone, not within the prostate. Surgery does not address that pattern of recurrence. And if a rare patient does experience local prostate recurrence after radiation, the prostate can actually be re-irradiated with techniques that work reasonably well. In short, this argument describes a real but uncommon scenario and overstates the practical risk while understating the equivalent risks after surgery. It is a reasonable consideration, but probably less decisive than many patients believe. Reason 6. Already significantly impaired erectile function, where preservation is not a primary goal. This reason works somewhat differently from the others. It is less a reason to avoid radiation and more a reason to reconsider radiation if erectile function preservation is not a meaningful concern. In general, radiation therapy is associated with better preservation of erectile function than surgical prostatectomy. This has been demonstrated in multiple randomized trials. The PROTECT trial, which randomized men to active monitoring, surgery, or radiation, found that sexual health was better preserved with radiation compared to surgery at most follow-up time points. More recent data from the PACE trial comparing stereotactic body radiation to surgery showed similar favorable outcomes for erectile function with the radiation approach. So, if erectile function is already absent at baseline and cannot be further lost, this advantage of radiation over surgery disappears. Conversely, if erectile function is currently present and its preservation is important to the patient, this actually argues for radiation rather than against it. Reason 7. Conditions making it impossible to lie flat and completely still. Radiation therapy requires the patient to lie still on a treatment table while the machine delivers precisely targeted radiation to the prostate. This typically takes somewhere between 10 and 30 minutes per session, depending on the technique. For most men, this is entirely manageable. For a small subset, conditions such as advanced Parkinson's disease, severe movement disorders, extreme anxiety, significant dementia, or other neuropsychiatric conditions make lying completely still for this duration impossible. When the body moves unpredictably during treatment, the machine cannot reliably target the prostate with the precision that modern radiation therapy depends upon, and surrounding structures receive unintended dose. This is a genuinely rare situation, but when it applies, it is a meaningful practical barrier to safe and effective radiation delivery. Reason 8. Severe active inflammatory conditions. Radiation therapy produces an inflammatory response in the treated tissue. This is part of how it works. For most patients, this produces manageable and temporary side effects. For patients with certain active inflammatory conditions, this inflammatory response can be amplified to a clinically significant degree. Conditions of concern include active inflammatory bowel disease, specifically Crohn's disease or ulcerative colitis during a flare, and active collagen vascular diseases, including scleroderma, systemic lupus, erythematosus, Sjogren's syndrome, and certain DNA repair deficiency syndromes. The important nuance here is the word active. A patient with a prior history of Crohn's disease that is currently in remission is not in the same risk category as a patient experiencing an active flare. Most radiation oncologists will proceed with appropriate monitoring in patients whose inflammatory conditions are not currently active. Our group conducted a comprehensive analysis examining patients with collagen vascular disorders and inflammatory bowel disease who received radiation therapy across multiple institutions worldwide. We found that severe side effects occurred in fewer than 15% of these patients. Grade 4 toxicity, meaning near critical events, occurred in fewer than 5%. There were no treatment-related deaths. These figures do not represent absolute safety guarantees, but they indicate that these conditions are relative rather than absolute contraindications, and that most patients can receive radiation with appropriate precautions and monitoring. Reason 9. Active surveillance or observation is actually the better option. This reason applies to men at lower risk than John, specifically those with low risk or favorable intermediate risk prostate cancer and an otherwise reasonable life expectancy. For these men, active surveillance, meaning monitoring the cancer with regular PSA testing, biopsies, and imaging rather than treating immediately, is an entirely legitimate and guideline-supported approach that avoids the side effects of any treatment while maintaining the ability to intervene if the disease progresses. For men with a limited life expectancy, typically under 5 to 10 years, observation without active treatment is similarly appropriate. Treatment of any kind, including radiation, carries side effects, and when life expectancy limits the window within which treatment benefit can be realized, the risk-benefit calculation shifts substantially. Let me also address two additional considerations that are not contraindications but deserve awareness. The first is strong opposition to hormone therapy. Hormone therapy, also called androgen deprivation therapy, is frequently recommended alongside radiation for men with intermediate and higher risk prostate cancer. It works by depriving prostate cancer cells of testosterone, which they depend on for growth. The benefits of hormone therapy, including reduced risk of metastasis and improved cancer-specific survival, increase with higher disease risk. However, hormone therapy carries significant side effects including hot flashes, loss of libido, fatigue, bone loss, and potential cardiovascular effects. For some men, these side effects are simply not acceptable. I respect that position. What I would ask is that patients understand the difference between a short course of hormone therapy, sometimes just 4 to 6 months, and the long-term courses required for higher risk disease, before ruling it out entirely. A brief course may have minimal quality of life impact while providing meaningful benefit. This is a nuanced conversation worth having with your radiation oncologist before making a final decision. The second consideration is prior pelvic radiation therapy. Men who have received radiation to the pelvis in the past for bladder cancer, rectal cancer, or other conditions present a more complex planning scenario. Whether prostate radiation can safely be delivered depends on where the prior radiation was delivered, how much dose was given, and how much time has elapsed. This is not automatically disqualifying, but it requires your radiation oncologist to review the prior treatment records carefully and incorporate them into the planning process. Now let us return to John. His IPSS score is 5, indicating minimal urinary symptoms. His erectile function is good, and its preservation matters to him. He does not feel psychologically that the cancer must be removed. He has no prior pelvic radiation and no active inflammatory conditions. He can maintain a full bladder and an empty rectum. He has no conditions preventing him from lying still. In John's case, none of the reasons discussed today apply meaningfully. Radiation is a genuinely appropriate choice for him, and he ultimately chooses it. Given his individual profile, this is the right decision. The point of this entire conversation is not that radiation is dangerous or inferior. It is excellent treatment for many men. The point is that the checklist matters. Your individual profile, your symptoms, your anatomy, your preferences, your other medical conditions, and your values around quality of life all factor into whether radiation is the right choice for you specifically. The best physicians are those who tell you clearly when their own specialty's approach is not your best option. Seek those conversations. Bring this checklist to your appointments. Ask your radiation oncologist directly which of these factors apply to you and how they affect the recommendation. This is Dr. John. Informed patients make better decisions. I will see you in the next one.